Hello, this is Stephen Holloway. Today we'll be discussing heart failure. This is Nursing 211. Your reading, as you can see here, comes from your med-surg book, your pharmacology book, and your pathophysiology book. Heart failure is defined as a clinical syndrome resulting from structural or functional cardiac disorders that impair the ability of the ventricles to fill or to eject blood. Heart failure is recognized as a clinical syndrome characterized by signs and symptoms of fluid overload or inadequate tissue perfusion. In the past, we referred to this as congestive heart failure. The new terminology is just heart failure. It was called congested because typically with left-sided heart failure, the fluid backed up into the lungs, causing the patients to feel congested, causing more pulmonary type symptoms. The term heart failure indicates myocardial disease. So when we hear the term heart failure, you can underscore that there is some sort of disease process going on with the heart or the heart muscle. Typically, there's a problem with the contraction of the heart, which is systolic failure, or trouble with filling of the heart, which is diastolic failure. Some cases can be reversible depending on when it's caught and what the underlying cause is. But most heart failure is a chronic progressive condition which needs to be managed with lifestyle changes and medications. Heart failure medical management, nursing management requires excellent discharge information, excellent management, and follow-up with the patients. It's up to the patient to make the lifestyle changes. But we as nurses must make sure that we're getting them the information they need, they understand the information we're giving, and they understand the consequences of not following these instructions. So we break down heart failure basically again into systolic and diastolic heart failure, but then we break it down into the signs of the heart. Left-sided heart failure is the inability of the left ventricle to fill or eject sufficient blood into the systemic circulation. Right-sided, similarly, is the inability of the right ventricle to fill or eject sufficient blood into the pulmonary circulation. Now, we've talked extensively about heart failure when we talked about congenital heart defects. It's the same process as we're looking at it. If we're not pumping the blood out of the ventricles, then it begins to back up. You must make sure you understand the flow of the blood through the heart to truly understand heart failure. So let's talk about the difference between systolic and diastolic heart failure. Systolic heart failure is the inability of the heart to pump. So the heart is not able to pump the amount of blood it needs into the systemic circulation to meet the requirements of the systemic system. So we're not getting enough nutrition, we're not getting the blood out, we're not getting the oxygen out. So we're going to see signs and symptoms that are related to the looking at basically at the systemic circulation. So also with systolic, basically, again, the heart is not pumping, so the ventricle, whether it's the right or left, is filling, and then the blood is going to be backing up. Diastolic, on the other hand, let me back up and say that with systolic heart failure, what we're typically going to see with these patients is a reduced ejection fraction. And that is the hallmark of systolic heart failure. Ejection fraction should be above 50%. As it drops, we're seeing more and more symptoms of the heart failure, whether it be right-sided or left-sided, whichever ventricle is not functioning properly as a pump. Diastolic failure, on the other hand, is basically the inability of the heart to pump because it can't fill. There may be some problem with hypertrophy, some problems with the valves, but there is some reason we cannot get blood into the ventricle itself. So really sometimes the heart can pump well, but we cannot get blood into that ventricle. And if we can't get blood into the ventricle, it cannot be pumped out into either the systemic or the pulmonary circulation. Sometimes you'll hear diastolic heart failure termed heart failure with preserved heart function. In other words, the ventricles are pumping correctly. We just have a problem of getting that preload into the ventricles so they can pump it out to either the systemic or the pulmonary circulation. So let's talk a little bit about how prevalent heart failure is. It is one of the leading causes of hospitalization in the United States. Right now, heart failure is affecting approximately 6 million people in the United States. There's some 870,000 new cases each year. Now, understand that the incidence of heart failure increases with age. And guess what's happening to our population? Our population is aging. So we're going to see more cases of heart failure as we move on. We see heart failure is most common in people older than 75 years of age. Again, that's because of the decreased pumping ability, typically the heart, as where age increases. The other thing we see basically is also we see a loss sometimes of atrial kick, because if you remember when we talked about atrial fibrillation increases as age increases. So if we lose that atrial kick, we're losing part of our stroke volume, so we're decreasing the amount of blood that's being pumped out. Heart failure is the most common reason for hospitalization of people age older than 65 years old, and the second most common reason for visits to a physician's office. It's estimated that approximately 25% of patients discharged after treatment for heart failure are readmitted to the hospital within 30 days. You need to understand, if a patient is readmitted to a hospital within 30 days, especially with the same diagnoses, the hospital does not get reimbursement from Medicare or Medicaid. The hospital pretty much has to eat that admission, if you will. It does not get paid. If the hospital is not getting paid by Medicare, Medicaid, there's money lost. And guess where they're going to start cutting? And nursing. Although we can singularly make the biggest difference in these patients by making sure we're teaching these patients about heart failure, about the things they need to do. One thing that you can see with heart failure, it does cause an economic burden on the United States, usually more than $30 billion annually, and that may include money spent on health care or money lost from not being able to go to work because of the heart failure. So what are some of the big causes of heart failure? Well, of course, we've talked about a lot of these. Coronary artery disease. If we've got severe coronary artery disease, we are not getting the blood to the muscle. They can't function appropriately, so we can begin to see damage to that heart muscle. Hypertension. Remember, with hypertension, we're increasing the afterload that the heart has to pump against. The harder the heart has to pump, the more the myocardial oxygen demand, the greater the risk for development of an MI. Also, we can see with that decreased preload, so we can also see some changes in that way. Cardiomyopathy is usually one of the things that we see. There's different types of cardiomyopathy, but with some cardiomyopathies, you get a thinning of the ventricular wall in a large diameter chamber. You're getting blood into the chamber, but you cannot get it pumped out. Other types of cardiomyopathy cause a restriction that we cannot get blood into the ventricles, or we get hypertrophy of the septal ventricle walls, thereby decreasing the volume within the ventricles. So we can see all of those causing problems. Another thing that we see is renal dysfunction. And with renal dysfunction, we're looking at overload of fluids in the person, so that will lead to the development of heart failure. This slide comes from your textbook, and it really talks about some of the physiology, pathophysiology that goes along with heart failure. You can see myocardial dysfunction leads to decreased cardiac output, decreased systemic blood pressure, and decreased perfusion to the kidneys. That leads to two things. It leads to the activation of baroreceptors, which are located in the left ventricle, aortic arch, and the carotid sinuses, and it causes the stimulation of vasomotor centers in the medulla, which activates the sympathetic nervous system, which increases catecholamines, which are epinephrine and norepinephrine, and causes vasoconstriction. The vasoconstriction then increases afterload, blood pressure, and heart rate. The other thing is the activation of the renin-angiotensin-aldosterone system. When we see that activation of the angiotensin 1 basically into the lungs, is converted to angiotensin 2. These angiotensin 2 basically causes a release of aldosterone, so we get sodium and water retention. We get more cytokinins released. We get, again, vasoconstriction, increasing afterload, blood pressure, heart rate. All of those, again, in combination, are going to cause multiple problems for the patient with heart failure. That's why ACE inhibitors and ARBs have been a real blessing in the treatment of heart failure, because they can block that change of angiotensin 1 to angiotensin 2 so that we don't get the increase in aldosterone, we don't get the vasoconstriction. So it really has made a huge difference in the life of the patient with heart failure and the long-term or longevity of these patients. There are different classifications of heart failure. This table comes from your med-surg book and basically is from the New York Heart Association. Basically what it looks at is just kind of looking at signs and symptoms. I'm not going to read the chart to you, but it gets worse as you go from 1 to 4. So 1 being the less, no limitations of physical activity. So really, if they're going along their normal pathway, there's no problems. But if they get into any distress, it can lead to symptomology of heart failure. As it goes on, it gets worse. Level 4 is basically these patients are unable to carry any physical activity without discomfort. These patients need major help to even survive. Now, this is the American College of Cardiology and American Heart Association's classifications. Again, very similar as they look at different things. So you go A to D, with D being the most patient with the most problems, and you can see that it talks about what's going on with the patient, some of the characteristics, and then some of the recommended treatment protocols for these patients. Again, I'm not going to read this chart to you, but you may want to look at it as we talk about going on. If we look at stage 1, these patients are at high risk for developing ventricular dysfunction. They can have hypertension, atherosclerosis, diabetes, metabolic syndrome. All of those can play part in this. And what we want to do is try to get these people healthy again. A healthy heart lifestyle, which is including diet, managing the diabetes, managing hypertension, exercising routinely, managing their weight, taking their medication, their ACE inhibitors, their beta blockers, whatever is necessary to maintain control of the heart failure. Again, look through this, kind of understand. The deeper we get into heart failure, the more things we're having to do. You can see stage B, we're adding more medications. Stage 4, adding more medications, or C. Then stage D, we're actually looking at life support type issues for these patients, whether it be cardiac transplant, whether it be LVAD, whatever is necessary to maintain, because at this point their heart just cannot maintain adequate cardiac output. So what are some of the clinical manifestations that we normally will see with heart failure? Left side, remember, with left-sided heart failure, The blood is backing up from the systemic circulation into the pulmonary vasculature. So just think about what kind of things you're going to see if you've got an abundance of blood fluid backing up into the lungs. Initially, the first thing you're going to hear, basically, if you listen to the patient's lungs, you're going to hear crackles. That could get worse as time goes along. Many times, if you listen to the heart, you can hear an S3 ventricular gallop. These patients may start complaining of some shortness of breath. They may feel dyspnea on exertion. If you ask them, they may be sleeping on 2 to 3 pillows at nighttime. They have to sleep on those pillows to actually breathe. If we check their O2 saturations, we may see sats dropping on these patients. They may have a dry, non-productive cough initially. As this progresses along, if it continues untreated, we can get into what's called flash pulmonary edema, and you're going to see that cough change from non-productive to a frothy white, pink colored sputum, and that's showing a lot of fluid getting into the alveoli letters. In these patients, you may see a decrease in the urinary output. It could even possibly develop into loss of urinary output, but we're not getting good perfusion to the kidneys at this point in time, so we're going to see changes in the urinary output. Now, let's talk about right-sided heart failure. Remember again, trace your blood flow through your heart. If we can't get the blood out of the right ventricle, then where is the fluid going to back up into? And of course the answer is the systemic circulation. So some of the things that we may see is basically JVD, jugular venous distension. We can begin to see some dependent edema. Now, dependent edema really means what it means. The edema is going to settle in a place the patient cannot move. If you have a patient that is bedridden, you're probably not going to see the edema in the lower extremities as you will someone who is sitting up and is walking. So consider where it's going to be. If this is a bedridden patient and we're able to elevate the head of the bed, we may see some fluid retention more in the lower back buttocks region. That's not uncommon. For most of these people, you're going to see dependent edema more in the lower extremities of the legs. Please remember when you're documenting edema, especially pitting edema, you need to document how much it pits, 1 plus, 2 plus, 3 plus, 4 plus. But also remember when you're documenting on the lower extremities, how high up does that edema exist? Is it just right at the ankle and stops there? Does it go up to mid-calf, upper calf, or even around the knee? Document the difference. If you may have 4 plus pitting edema in around the ankle, but you get up to the mid-calf type area or even into the folds of the skin there, you may see a much greater amount of, or lesser amount of edema. So you need to document it. So document basically how much edema you're having and how high up it goes, especially on the legs, so that we can track that. Again, we're going to be looking for those signs and symptoms that go on with that. We also can see fluid buildup in the liver, hepatomegaly. We talked about that with the children. We also can actually see a transfer of fluid from the vascular space to the extravascular, so we can see buildup of fluid in the abdomen, some ascites type issues. Yes, we want to follow intake and output on both of these patients, but we also want to make sure we're getting a daily weight on them. That daily weight in the same clothing at the same time is going to give us a much greater indication of how much fluid gain or fluid loss this patient has had. So remember, daily weights are important, but not just the one you took today is important. It's the one you look at in a series of measurements so that we can see if there's been progression or degression of the fluid volume type problems that go along with these patients. The goals of medical management of heart failure are pretty simple. We want to improve cardiac function with optimal pharmacological management. We want to reduce the symptoms, improve the functional status of the patient. We want them to live a more active lifestyle if they choose to do so. We want to stabilize that patient's condition and want to lower the risk of hospitalization or rehospitalization for these patients. We want to delay the progression of heart failure and extend the life expectancy of this patient. The main thing we need to do a lot of these is promote a lifestyle that is conducive to cardiac health. So all of those are things that we really must try to do as we manage these patients with heart failure. Again, as nurses, the big thing that we have to do is proper education. We need to educate these patients in healthy lifestyle, daily weights, taking their medications, fluid restrictions if necessary, all of those, diet, exercise, all of those are so important, and that's where we come in as nurses trying to provide the education to these patients. Now, here's medical management as we look at it. Medications. The medications we typically are going to use with these patients are ACE inhibitors, angiotensin II receptor blockers, hydralazine and isorbid dinitrates, beta blockers, diuretics, digitalis, and sometimes antiarrhythmic medications. Now, the angiotensin converting enzyme medication, or your ACE inhibitors, play a pivotal role in the management of systolic heart failure. What happens is they've been found to relieve signs and symptoms of heart failure and significantly decrease the mortality and morbidity. This is especially true in patients with left ventricular ejection fractures less than 35%. These ACE inhibitors slow the progression of heart failure, improve exercise tolerance, and decrease the number of hospitalizations. But again, the patients must take the medication. What's one of the reasons that patients many times stop taking these ACE inhibitors? Correct, cough. The big side effect of these medications is kind of a dry, hacking cough. But if you look back, one of the clinical manifestations could also be a cough for this patient. So we've got to help the patient decide what is what. Is this from medication, or are they increasing symptoms for these type processes? Remember that the ACE inhibitors promote vasodilatation and diuresis, which decreases afterload and the preload. The vasodilatation also basically decreases afterload, so the left ventricle does not have to pump as hard. So it's going to improve the heart's workload, improve emptying. It's going to really make things better. The big thing we talked about earlier when we looked at it is ACE inhibitors decrease the secretion of aldosterone. And if you remember, aldosterone basically is a hormone produced in the kidneys that helps to retain sodium and water. So these ACE inhibitors promote renal excretion of sodium and fluids, but hold on to potassium. So we're reducing left ventricular filling pressures and decreasing pulmonary congestion. So ACE inhibitors have been really a godsend, if you will, in the treatment of heart failure. Now, the other medications, the ARBs, are a little different from the ACE inhibitors, but they have very similar hemodynamic side effects. Whereas the ACE block the conversion of angiotensin 1 to 2, the ARBs block the vasoconstricting effects of angiotensin 2 at the angiotensin 2 receptor sites. So ARBs are prescribed for heart failure patients as an alternative to ACE inhibitors. Now, the hydralazine and the isorbid are basically both vasodilators. They call venous dilatation, which reduces the amount of blood returning to the heart and lowers preload. Hydralazine also lowers systemic vascular resistance and left ventricular afterload. So this is a combination of medications that's also recommended in use in heart failure. These tend to be more effective for African Americans because many African Americans do not respond to ACE inhibitors. Has something to do with enzymes and breakdowns of the medications. Beta blockers are also considered a first-line therapy. and are basically prescribed in addition to the ACE inhibitors. They block the adverse effects of the sympathetic nervous system, relax blood vessels, lower blood pressure, decrease the afterload, and decrease cardiac workload. These basically work very well just to decrease the cardiac function, decrease the oxygen need for the heart muscle themselves. Big side effect of these, of course, can be with any beta blocker is slowing the heart rate. So we do need to monitor the patient's heart rate and make sure the patient monitors their heart rate for that. Also, remember with beta blockers, we have to make sure these patients don't have any history of asthma, because the beta blockers can actually cause bronchial constriction, leading to asthma attacks. Of course, diuretics are used. Diuretics are used to actually pull off this extracellular fluid so that we're getting it out of the patients. Remember that loop diuretics pull off potassium, so we need to watch the potassium on these patients for sure. Again, the best thing for these patients, we do like them to look at their urine output, how much are they having. And again, some of this diuretics can be kind of not have to be used if we can talk our patients in and help them understand they need to adhere to a low sodium diet and a fluid restriction, usually less than 2 liters per day on the fluid restriction. Digoxin, again, is a positive inotropic and a negative chronotropic drug. Positive inotropic means it increases the contractility of the heart, where a negative inotropic decreases the rate of the heart. It's been the mainstay for any type of heart failure in the past. The big problem is basically it has a very narrow therapeutic range, so the chances of toxicity are great, and we have more problems if there is problems with potassium. So if we're using a diuretic that lowers potassium and we're using a digoxin compound, so we have a greater chance of dig toxicity from these patients. So we have to monitor that very, very closely. Of course, we want, as we talked about, we want these patients to have a low sodium diet. The more sodium, the more fluid they're going to withhold. And then fluid restrictions. It's going to depend on what stage they're in for their fluid restrictions, and that's going to be up to the physician. Your job as a nurse is to help them understand how much fluid restriction they have and ways to actually keep their mouth moist, ways to actually keep that fluid restriction but still feel like they're getting more fluids in than they normally do. Oxygen therapy may be used on some of these patients depending on their O2 saturations and the degree of problem with the heart failure. Now, this is just a overview of the different medications. You can take a look at this. I believe this one comes actually from your med-surg book. So it is from your med-surg book. It's table 29-3. So it just goes through what we've just talked about. I would take a look at this chart because this would be a great place to pull test questions from, because medical management and as nurses teaching these patients about these medications and how they need to take them, why they need to take them, is part of our responsibility as nurses. Other medications that you may see, these are more used in hospital type processes, and these are milrinone and dobutamine. Now, you should have had to do a drug information sheet on dobutamine. I don't think we had you do one on milrinone. Milrinone is a phosphodiesterase inhibitor. Yes, that's the same classification drugs as the erectile dysfunction drugs. But this leads to an increase in intracellular calcium within the myocardial cells, increasing their contractility. It also promotes vasodilatation, which results in decreased preload and afterload and reduces the cardiac workload. This medication is given IV, usually as a continuous IV infusion to these patients. and it's used a lot of times if if they've gained much weight and we need to get the fluid off. It may also be used in patients at the end stage trying to maintain them so that they can get to transplant or some sort of ventricular assist device. The major side effects basically from this medications are hypotension and increased ventricular dysrhythmias. So we must make sure we're monitoring the blood pressure and the cardiac rhythm of these patients. Now, of course, dobutamine is the drug that many doctors still prefer to use. They like to use it simply because it's going to increase the stimulates the beta-1 receptors, so it's going to increase the contractility of the heart. The good thing is it's going to increase contractility with minimally increasing the heart rate. Now, we can use other drugs such as epinephrine to increase the contractility, but it's also going to increase the myocardial oxygen demand. Digoxin can also increase that myocardial oxygen demand. So dobutamine is a good drug in hospital to use. We can use it as a continuous infusion, and it's going to work well to help increase the contractility of the heart to help pull off the fluids from the patient. We have to have good contractility and good perfusion to get the blood to the kidneys. Diuretics are not going to work if we're not perfusing the kidneys, so the dobutamine works very well to help perfuse the kidneys. It's not uncommon to see basically a furosemide drip, a dobutamine drip, and a dopamine drip going on the same patient. Lower levels of dopamine up to I believe it's about 5 micrograms per kilograms per minute, actually causes what's called a renal artery vasodilatation. So it makes it easier to get blood flow to the kidneys. So if I'm increasing the easiness of blood getting to the kidneys, I'm increasing the contractility with the dobutamine, and then I'm giving a diuretic to pull the fluids off, I can diurese patients a little bit faster. So don't be surprised if you've got a patient that is in chronic heart failure or they're having symptoms of flash pulmonary edema to see 3 of these medications used on that same patient. It's very, very common to see. Okay. Other measures that we can use that are really for these patients who are very, very chronic in their nature, and maybe they come in and they have gained 15 pounds or better. It's hard to say, but basically one of the things we can do is we actually can use a system called ultrafiltration, which very much works like dialysis without pulling out a lot of the electrolytes and the bad things in the blood. All it's going to do is pull out fluid. So typically this when a patient comes in, they'll go ahead and be started on maybe a furosemide drip. And if that's not really diuresing them well enough, they will switch to ultrafiltration. Now at Huntsville Hospital, ultrafiltration normally takes place on 3 East, 3 West. The nurses there have been very trained on that. Occasionally you will see it up on the 6th floor. But these patients require central line to be put in place. Many times it's a PICC line. You have to have an input-output type area. So you've got blood coming out, going into the machine, and then you've got another port where we're putting blood back into the individual. These patients do have to have a heparin infusion. It's a little different than the normal heparin that we see for other things, but they will have to have heparin to keep the blood from clotting. This just goes right at the bedside. The patient just stays in bed. This machine works and it pulls fluid off. It goes through a chamber that basically has a lot of the tubing like dialysis does, and it allows that transfer of fluids, water across those membranes to actually be dumped down into this bag. So very, very effective means of actually helping to diurese a patient to get the fluids off. Remember, what we're trying to do is actually get the fluid off, not try to take off the electrolytes as far as those. Again, we've got to monitor our blood pressures closely. We've got to monitor their hemoglobin, because we can get some either hemoconcentration if we go too fast, or we can get some breakdown of the blood cells. But again, seeing good effectiveness of this type of device with heart failure patients on 3 East, 3 West. One of the other things that we can see with these patients is basically resynchronization pacing. As we see with some of the different types of processes, there's a change. You may have had damage in the left ventricle and no damage in the right ventricle. So the synchronization of the left and right going at the same time will not be the same. So because of the changes, there's a difference in the blood flow. So we need them to be synchronized. So in some cases, they will go in these patients with chronic heart failure that maybe have some hypertrophy or some other problems going on, and actually put in a pacemaker so they can actually synchronize the contractions of both ventricles, so that both ventricles fire at the same time, pushing out their load of blood either into the systemic or the pulmonary circulations, but they're doing it in rhythm, if you will. That really does help improve the function for these patients. It requires, again, just going to the cath lab to be put in. Typically, these are patients who have a very large left bundle branch block. Some of the desynchronization can come from basically a hypertrophy, as we talked about. So again, it improves cardiac output and optimizes myocardial energy for these patients. One of the things that we see, these patients do tend to improve. We see fewer symptoms in patients who have had this resynchronization therapy, fewer hospitalizations, increased functional status, and longer survivability. This is now used along with other type processes for these patients. If you want to see more about it, go to your chapter 26 in your book, and they're going to talk very specifically about this device. The other thing that has become more prominent in these patients are assist devices, devices that are inserted, that are invasive devices to assist the function of the left ventricle. We really is more concerned about the left ventricle, because if we see backup of blood into the pulmonary vasculature, into the lungs, then we're seeing problems with breathing and oxygenation. So there are devices out there that are being used today to assist that left ventricle. Now, some of these are short-term devices. Some of them can be long-term devices. Intra-aortic balloons, or counterpulsation, you may hear it called, is a type of assist device to help the patients who are in heart failure. These are usually your patients with your ejection fractions down less than 20%, that we see a lot of these patients, especially our patients who are going for bypass graft to actually maybe hopefully get a little bit more fluid, more oomph, if you will, to rest the heart. Sometimes if we've got someone in cardiogenic shock, we just need the heart to rest for a while, we may use a balloon pump. How a balloon pump works basically is it's inserted through a femoral artery and goes up through the aorta up to just below the aortic arch. You can see here where basically you have the aorta, and it comes over and goes over to the arch here. So they want the tip of that balloon just below that aortic arch. And basically the balloon can be different lengths and different sizes. So what's going on with this balloon basically is that just before the heart as the heart is resting, as the heart is not pumping during diastole, the balloon inflates. When that balloon inflates, blood that is in the aorta is pushed either back toward the heart or down toward the systemic vasculature. So one of the things it does is basically by inflating, pushing blood back up into the aorta, it's usually pushing blood into the coronary arteries. Remember, the coronary arteries fill off the aorta. So we're increasing blood flow to the myocardium during this time. So we're helping with that blood flow to the myocardium. So hopefully we can slow that heart down, let that heart pump more effectively. Now, just before the ventricles contract, the balloon deflates. As that balloon deflates, basically it's leaving kind of a void, if you will, in the aorta. It's reducing the pressure that the heart has to overcome to push blood into the systemic circulation. So the balloon pump has done two things. We're perfused our cardiac muscle much better, and we're decreasing the afterload so the ventricle does not have to pump as hard to get the blood out. So we're increasing cardiac output and also increasing the oxygen supply to the myocardium. So again, this is a temporary type process. With the interaortic balloon, you can set it to 1-to-1, 2-to-1, or 3-to-1, where that basically, actually I said that wrong, it's 1-to-1, 1-to-2, 1-to-3. So 1-to-1 basically means for every time the heart beats, the balloon will inflate and deflate. 1-to-2 means that basically every other heartbeat, the balloon will inflate and deflate. 1-to-3 means every third beat, the balloon will inflate and deflate. And they'll use that sometimes as a weaning method to see how the patient is doing. Again, can be used prior to surgery, especially cardiac bypass graft, valve surgeries, just to give the heart a chance to rest a little bit before they start working on it. Can be also used for congestive heart failure to kind of just give the heart a chance to rest, to get that blood pumping to the other parts of the body as part of that process. Now, you have YouTube links to go in there and look at that. I think it's very good, and it should be in Blackboard for you as well. So if it doesn't work from the slides, you can pull it there. Another left ventricular assist device that you may see, typically these patients are going to be in the ICU area, is called an Impella. An Impella is a device that's inserted very much like through a cardiac catheterization. It goes through the femoral artery, up through the aorta, and then from the aorta into the left ventricle. Typically it's done for left ventricular failure, not right ventricular failure. It has a rotating blade system on it that actually pulls blood from the left ventricle and pushes it on up into the aorta, thereby unloading the left ventricle so it's not overloading and allows more blood to get into the systemic circulation. It actually acts more blood into the coronary arteries as well. The side effect of this particular device are, one, the patient has to remain in the bed because the leg has to remain straight, just like with any type of PCI procedure. There's always a risk of bleeding at the site, risk of embolization around the area, so you've got to check the pulses distal to the insertion site. The other thing is, because it uses a propeller type device, as you can see here in the insert, it actually turns at very high revolutions per minute, RPMs. It actually can break down red blood cells. So we can see some anemia develop because of the breakdown of red blood cells. So this is not designed for long-term, but for short-term use. So again, this may be something that you see. Again, it goes into the left ventricle and actually pulls blood through a device here, takes it back up this way, and it disperses the blood out into the aorta from that site there. So you're getting blood from the left ventricle into the aorta to go out to the systemic circulation. Watch the YouTube video. It's pretty explanatory. But again, remember, your post-op care or your care for this patient while they're in your ICU under your care is very much like any patient that's having a PCI. You've got to watch that site. You've got to watch for bleeding. You've got to watch for distal circulation. You've got to watch the blood pressure. You've got to watch the H&H. You've got to watch for signs of infection. All of those are part of the process with this device. Another temporary assist device that you will see is called the tandem heart. You can look at the video sites to look at it. It's a little different in that it goes through the venous system, goes up through the inferior vena cava, and then actually uses a puncture through the atrial septum to actually enter the left atrium. At this point, it's connected to an external pump. Blood is then pulled from the left atrium and pulled back down through the system, and actually the pump is then connected to the systemic circulation through an arterial puncture here, so that blood can be then delivered to the circulation. It is a very complicated device. It is new. The benefits over the Impella is the lack of breakdown of red blood cells and the lack of a femoral stick. The differences are, number one, you're creating an ASD from there, but again, it's this a temporary type process. It basically unloads the left atrium, left ventricle, returns that blood to the systemic circulation, and actually helps in those type devices. So it's a temporary device. Nursing management, the puncture site, risk for infection, watching your blood counts, again managing a controller that it's getting the right RPMs, it's not getting too hot. So many things that will go along with those. You may or may not see these if you are at Huntsville Hospital at some point in time. I know they're trying to move to these. You may actually see one in use. Chronic long-term left ventricular failure, heart failure, basically these patients are going to require a transplant at some point in time. Now, there's just not enough hearts to go around to transplant everyone that needs a heart transplant. So many times these patients will need something to help them make it through till a heart is available. And this is called a left ventricular assist device. It's basically a pump that is inserted into the chest. It basically pulls blood from the left ventricle and then actually pumps it into the aorta. Again, it is internal. So the patient doesn't show if you're looking at. If you see a patient, and what you're going to notice is they're wearing battery packs and a controller. One battery works at a time. If there's battery failure, then it switches to the other battery. Typically, the big thing for these patients is they're going to have a heart transplant at some point in time. So that is the big concern with these patients. And that's the problem with heart failure, is typically they're going to need a heart transplant at some point in time. So that's one of the things that we have to be aware of. Again, left ventricular assist device is for long-term heart failure patients. So let's look at the nursing care of patients with heart failure. Let's talk about assessment. The health history needs to focus on the signs and symptoms of heart failure, such as dyspnea, fatigue, edema. Are they having any sleep disturbances? Are they having to prop up on pillows to sleep? Are they being interrupted from the sleep by periods of shortness of breath? Ask the patients about the number of pillows they sleep on. Are they noticing any dependent edema? Are they noticing any abdominal symptoms? Are they noticing it looks like there's fluid building up in their abdomen? Any altered mental status? How are they doing with the activities of daily living? Are they able to do them without getting fatigued, or just doing minor things is making them seem much more fatigued as they go along with their life? Um, those all can be very, very telling of increasing heart failure. Uh, Basically, also assess their understanding of the heart failure. What do they understand the self-management part? Do they know how to take their medications? Do they know how to weigh themselves each day? Do they know what their medications are for? Do they know about their fluid restrictions? All of those you need to get um, in your fluid, in your assessment of the patient. And really, as you're assessing the patient, ask them about their weight history. Have they seen a change in their weight history? Are they seeing the weight increasing? Uh, and typically we have goals. I will be posting on your blackboard a little chart that talks about red, green, and yellow areas for patients, and it gives them guidance of what to do with certain things occur. So again, reviewing that with them, that needs to be done before they're discharged from the hospital. If you're working in a clinic with these patients, it needs to be done each time they come in to see you. Don't forget to talk to them about the emotional and psychosocial issues that go along with this, because you may have someone that has been very active, and now because of the heart failure they can't do as much as they want to. Take a look at that, see what's going on with those issues. Of course, always get your health history, what's been going on in the past, what other underlying processes are going on. Did they have an MI? Is there a history of cardiomyopathy, history of rheumatic heart fever? Is there a history of any kind of diabetes, hypertension, anything that can lead to cardiovascular disease? All that needs to be reviewed. Talk to them about, do they smoke? If they still smoke, or did they smoke? How long did they smoke? All of those are important health history issues to address with your patient. Your physical exam, focus number one on your patient's mental status. Have they noticed changes in their mental status? Are they alert? Are they oriented? Are they confused? What's going on? That can tell you a lot about their oxygenation process. Listen to their lungs. Are you hearing crackles and wheezing? If you're hearing crackles, how high up are the crackles there? Are they coarse? Are they fine? All of those. Heart sounds, listening for that S3 type sound that can indicate heart failure. Look at the peripheral edema. Remember, when you're looking at the edema, especially pitting edema, how much does it pit? 1 to 4 type process, depending on how far down it goes. How high up does that edema go on? Does it go to the knees? Does it go on up to the thighs? How far up does that edema extend? Look for JVD, as you're doing those. When you're doing your abdominal assessment, do you feel any ascites? Do you feel any enlargement of the liver because of fluid overload there? Look for signs of fluid overload. Review their daily weights, review their intake and outputs. All of those need to be well looked at. Now, assess response to medications. This is really important in the hospital. When we give patients medications such as an injection of furosemide, Lasix, how well did it work? Go back and find out. Follow up with that patient. How many times have you urinated? How much did you urinate since I've given you this injection? So make sure you're following back up with that. Same thing if we're doing things such as pulling off the fluids. Look at those, see how much it's been pulling off. Look at some different things. If we're on the dobutamine, are we seeing increases in the cardiac output, fluid output? All of those are important to assess the responses to the medication. Also ask them about side effects, the medications, especially when they come in. Most of them are going to be on that ACE inhibitor. Are they having the side effects of the cough that goes along with that? So some of the nursing diagnoses that are related to heart failure: activity intolerance related to decreased cardiac output. Our goal is to promote activity and reduce fatigue. You can see some of the interventions here: bed rest for acute exacerbations. We want to encourage them to have some physical activity. The goal is to get 30 to 45 minutes a day. Now, they're probably not going to start out getting there, but again, making sure we help them work toward a goal. And set goals for each visit if you're working in a clinic. By the next visit, I want you to reach 15 minutes a day. Maybe the next week it's 18 minutes. Maybe the next time it's 20 minutes till they're working up to that 30. Exercise training, there's a good chart in Hinkle on 29-4 that really goes into helping these patients do well as far as exercise. It helps them do that. So take a look at that. We need to, especially if they're in the hospital coming in with an exacerbation, help them pace their activities. We want them to make sure that they are grouping their activities together that will help them do that, not to overdo. This is one thing you can really teach your patients. They need to wait 2 hours after eating for physical activity. Remember that eating, especially and when you're talking to them about eating, avoiding heavy meals. The heavy meals are going to make it even worse, because what's going to happen, you're going to get a shift of blood flow to the mesentery, to the gut, and so you're not going to have the blood for the other areas. So avoid that eating and for 2 hours, or avoid physical activity 2 hours after eating. Just like we do with most of our patients, avoid activities in extreme hot, extreme cold, or humid weather. You definitely don't want them going out if the heat index is 104 degrees. Ask them before they go home, do you have a good place to exercise? If they say no, look at things that they may do. There may be a church in their area that has a gymnasium they can go walk. There may be a rec center in their area where they can go walk. So some of these things, it may be just walking around their living room and kitchen, but in helping them get that exercise in. Now, the other things, modifying their activities to conserve energy as we get into those level 3 and 4 type processes really becomes important. Positioning, again, if they're having problems breathing, if they're having left-sided heart failure, we may need to get them in a bed that raises. We may need to make sure that we're getting their feet up if it's right-sided heart failure. So talk to them about those type issues that goes along with those. Excess fluid volume related to heart failure. Again, we want to relieve that fluid volume overload. Make sure they're assessing themselves for symptoms of fluid overload, and you're assessing them when they're in the hospital. Daily weights, same time, every day, same scale, same clothing, and we're watching those for changes, okay? Intake and output, so very important. Help them at home understand all the fluids they're taking in. They may not understand that ice cream is considered a fluid, or that Jello is considered a fluid. Help them understand that maybe if you're thirsty a lot, chew on ice chips, because a cup of ice chips only gives you half of the water intake of that. Diuretic therapy, timing the medications. We want them to take their diuretics in the morning if possible. We don't want them taking them at bedtime. We don't want them up going to the restroom 3 and 4 and 5, 6 times at night. It really defeats the purpose of that. Fluid intake, fluid restrictions. If they have fluid restriction, help them break it down so that they know that basically so much at this point in time, this much in the evening, and very little at nighttime. And then maintaining a sodium restriction, helping them to read labels to know, when they're looking what has salt, what doesn't have salt. And guys, there's nothing wrong with consulting a dietitian to come help you with this. Many times there are classes that these patients can go to assist with this. Bring in their family members so that they can help as well. The family members may love McDonald's French fries with all the salt, but they don't need to eat that in front of the patient because they're going to want it. The salt's probably not good for them either. But again, bringing in families, especially in older males who the women do the cooking, which is more of our older population, may not be more now, but whoever's preparing the meals needs to understand about that sodium restriction and fluid restrictions that go along. Anxiety, again, We want to try to reduce that anxiety as much as possible, because the anxiety is going to cause a release of catecholamines. Catecholamines is going to cause an increase in the heart rate. The contractility of the heart require more oxygen concentration. We're going to get the increase in blood pressure, which is going to increase the afterload. So all of those type things. And it may be that you need to call in a social worker or some sort of counselor to help them with those type issues. Powerlessness. These patients many times do feel powerless because this is a chronic disease, and maybe they didn't have any control over this. One of the things that we see many times with heart failure, and goes into some of the cardiomyopathies, is all they did was get a viral infection, and that viral infection destroyed part of the heart tissue, and now they're in failure because the heart can't pump as well. So these folks really are feeling that powerlessness at this point in time. If they've got a left ventricular assist device, they're so tied to that. They're waiting on a heart, and they have no control. And sometimes they have guilt. I apologize for the coughing. I couldn't get to the pause button soon enough. But many times these patients, even after the heart transplant, have guilt because someone had to die for them to get a new heart. So many times psychological type processes go along with these disease processes. Try again to get the patients involved in their own care. Let them be part of that decision-making process. What kind of foods do they like? As much as you can involve them in the care, do that. Again, therapeutic regimen, ineffective family therapeutics. Again, involve the family as much as possible. Knowledge deficit. This is one of the big things that these patients don't know. And again, when we are doing teaching, go back and review from your 113, 114. I'm not sure where it comes in the lower levels. Is patient education. We need to make sure, not just ask, do you understand? Have them talk back to you. Have them repeat back to you what you've just taught them. Teaching may need to be short periods of time. Again, if these patients are getting very tired, we don't try to sit them in an hour class. We may need to do individualized teaching with them for short periods of time. Again, include the family if at all possible. Are they ready to learn? They may be in denial and they're not ready to learn. So look at those type issues as you're doing that. Also look at some of the cultural factors that may go into the education, and include those plans accordingly. Now, let's talk about extreme complications of heart failure. When we talk about extreme, basically what can happen is the patient there may be some overwhelming complication happen, that these patients move from being going along and doing normal, and then basically go into a huge process called pulmonary edema or flash pulmonary edema. This is basically happens when there's an abnormal accumulation of fluid in the interstitial spaces and the alveoli of the lungs. Basically, it's always diagnosed associated with acute decompensated heart failure, and it can lead to acute respiratory failure and death. So with these processes, these patients need to recognize if they suddenly become very short of breath, they start coughing up pink frothy sputum, they can't breathe, their O2 saturations are dropping, that's a medical emergency. They need to call an ambulance right away, because they need oxygen right away, and they need to be diuresed as quickly as possible. The clinical manifestations of this pulmonary edema include coming up to it, they may notice they're getting restless and anxious. That's because of the hypoxia that's coming on. There may be a sudden onset of breathlessness and a sense of suffocation. They may be tachypneic, and there may be kind of some wheezing going on because of the fluids building up. You're going to see low oxygen saturations. Your skin and mucosal membranes may be pale to cyanotic. Typically, these patients are going to be tachycardic and are going to exhibit JVD. One of the big things that we see is incessant coughing, but the big thing that you're going to see is this pink frothy sputum. If you see someone with these symptoms, the restlessness, the anxiousness, the low oxygen saturations, and they're coughing up pink frothy sputum, you should automatically think pulmonary edema. This is a medical emergency, and we need to get this treated immediately. The changes in the restlessness, all that's because of decreased cerebral oxygenation. These patients, again, need to be treated medically as quickly as possible. This is how we're going to treat them. We've got to get oxygen on them. We've got to get those O2 sats up. If nasal cannula may not be enough, we may need to get them on 100% oxygen, so they may need to be put on either a Venturi mask or a non-rebreather mask so that they're actually getting 100% oxygen as part of that process. Lost my place, guys. I'll give you just a moment. So think about that. Diuretics is the other thing, and we may be doing bolus diuretics, or we may be doing continuous infusions, and we may be using more than one type of diuretic with these patients. We may be giving Lasix bolus and then starting them on the Lasix drip. We may actually put them on vasodilators to actually help dilate the vessels so we're not getting as much preload back to the hearts. Morphine is typically the drug of choice that we're going to give immediately. These patients are going to be very anxious, and because of the anxiety, the heart rate's going up, they're breathing harder. The morphine is going to basically decrease the respirations, decrease their anxiety. It's also called a vasodilatation type process. So all of that's going to take place with this. Now let me go back up and just say, when we talk about oxygen, in many cases, these patients may go into respiratory failure. These patients may have to be intubated and put on a ventilator till we can get this heart under control, get this edema under control. These patients may end up having to go on a balloon pump to allow the heart to rest at that time. But hopefully by the use of usually nitroglycerin for vasodilatation, the milnirone we talked about earlier, we may be giving them IV and getting them started on the milnirone, which is a vasodilator and because of cardiac cardiac contractions, or dobutamine may be used as part of this process. Positioning, again, you want to try to get that head up so they feel like they can breathe. And again, these patients are scared. They need some support. Don't go away from them if they need help as you're looking at that. My very first patient I had in nursing school was at Parkway Medical Center. We were in the ICU, and I was giving my patient his AM care. And all of a sudden, he just said, "I'm not feeling well." He started breathing faster. You could see his O2 saturations go down. And then all of a sudden, he started coughing up this pink, frothy sputum. It was scary for him. And I promise you, as a brand new nursing student, it was scary for me. But basically, the nurses there working with me recognized this, jumped into action, and we got this gentleman started on some diuretics, some morphine, some oxygen, and he actually did well. And so, but again, this is something that you may see with these patients. So be aware that if someone has heart failure, this is a complication that can occur as part of that process. Cardiogenic shock. Really, the acute pulmonary edema is just one step away from the cardiogenic shock. What cardiogenic shock basically, what is shock? Shock basically is the inability to move oxygen and nutrients to the tissues. And all cardiogenic shock is the inability to move those nutrients and everything due to lack of contractility of the heart. Typically, cardiogenic shock is a very life-threatening condition with a high mortality. If the heart function has dropped that low, then typically there's going to be long-term consequences. This patient, if they move into heart failure, the decision is going to be what to do. what type of assistive device are we going to use, left ventricular assistive device. Are we going to put in a balloon pump? Are we going to do an Impella, a tandem heart? Can they tolerate these type processes? But again, it's all about supporting and getting proper circulation back to these patients. Heart failure, complications, cardiogenic shock. Typically, these are the things that are going to lead to cardiogenic shock. A large MI. One of the students asked me, what is a widowmaker? And that's where basically you've got a blockage of the left high in the left anterior descending. So if that gets blocked, we wipe out a large amount of heart muscle. Those patients are very prone to going into cardiogenic shock because we lose so much of that heart muscle. We see it with end-stage heart failure. We see it with cardiac tamponade. We can also see it with pulmonary embolisms and cardiomyopathies. All of those can lead to heart failure. Again, medical management, we've talked about a little bit of this already. Oxygen, pain control. These patients may need a Swan-Ganz pulmonary artery catheter put in place so we can monitor hemodynamically. They may need fluid therapy, or they may need basically fluid pulling off fluids. Inotropic medications, the dobutamine, dopamine, milneurones, chronotropic, slow the heart rate down, vasodilators. We may need, in some patients, vasodilators. Some patients, we may need vasoconstrictors. So we may either need to decrease the afterload or preload and increase the afterload. It depends on what's going on in the patients. Diuretics is a big part of that. Again, ventricular assist devices, the balloon pump, the Impella, the tandem heart, all are going to be used for these patients. So if you have questions related to heart failure, please send me an email, catch me after class, and we will try to answer those questions for you. Have a great day.